This is Chapter 16, Nursing Care of the Family During Labor and Birth. Labor begins with the first uterine contraction and continues with hard work during cervical dilation and birth, and ends as the woman and family begin attachment process with the infant. Nursing care focuses on assessment, support, and the best possible outcomes for mom, baby, and the family. True labor, contractions are regular, become stronger, last longer, more intense with walking, and continue despite comfort measures. They involve the cervix, show progressive changes, and the fetus engages in the pelvis. False labor, there are regular contractions and they often stop. The cervix may be soft with no significant changes, and the fetus presenting part is usually not engaged in the pelvis. First stage of labor begins with the onset of regular uterine contractions and ends with full cervical effacement and dilation. In most pregnancies, the fetus reaches maturity and the uterus begins the process of labor at exactly the right time. 3 phases of labor. Their latent phase, during the first stage of labor, is up to 3 centimeters of dilation. The active phase is 4 to 7 centimeters of dilation, and transition phase is 8 to 10 centimeters of dilation. Women should be educated about the stages of labor. They should be informed of the possibility that they may not be admitted if they are 3 centimeters or less dilated. The ideal setting for the low-risk woman is the familiar environment of her own home. The nulliparous woman seeks admission during the latent phase. Multiparous women do not usually come to the hospital or birth center until active phase to determination of true or false labor. When the woman and her family arrive to the unit, assessment is a top priority. You want to establish a therapeutic relationship. Make the family feel welcome, determine the family and the woman's expectations about the birth, convey confidence, use touch for comfort, but respect cultural boundaries. During the admission history, you'll take a health history, personal data, histories of any previous illnesses, problems with any pregnancy, previous or this one, preferences for labor and delivery, and the preparation for the childbirth. Once the woman has been admitted and her labor process has been assessed, the information regarding health history is collected. EMTALA. This is the Emergency Medical Treatment and Active Labor Act, federal regulation enacted to ensure that women receive emergency treatment or labor care. Nurses must be familiar with their responsibilities. Agencies must have policies and procedures in place to ensure compliance. It's on page 402 of your textbook, providing medical treatment to pregnant women when they experience a medical emergency. All hospitals must have emergency provisions set up to meet these standards of care. Assessment in the nursing diagnosis. Your admission data would be prenatal data, the interviews, psychosocial factors, stress in labor, and cultural factors. The woman's prenatal records are usually on file, and the partner can serve as a secondary source of information. You need to always observe HIPAA. The woman will give permission for the person with her to give this information. Knowing the woman's age is important also, so you can plan according to the patient's age. Signs of impending labor are lightening, spontaneous rupture of membrane, bloody show, cervix ripens, Braxton Hicks contractions, nesting, and loss of 1 to 3 pounds. This is a picture of the electronic medical record. Since the enactment of the Health Care Act, electronic medical record is required to be used in most hospital settings. You just need to be familiar with electronic medical record and accurate record keeping on your patient. This is a picture of a room set up for a mother. There's safety equipment on the wall, O2 suction set up, cardiac monitor, and a pulse ox. Assessment in the nursing diagnosis. Physical examination. There's a general system assessment, vital signs, Leopold maneuver, and assessment of the fetal heart rate and patterns. Leopold's maneuver. Start by step 1. Stand on the right side, face the woman, and palpate the palm with palms of the hands. We do the Leopold's maneuver. It's performed with the woman lying on her back briefly. We help to identify a number of fetuses, the presenting part, fetal lie and fetal attitude, the degree of descent into the pelvis of the presenting part, and expected location of the point of maximal endpoint, PMI, of the fetal heart rate on the woman's abdomen. Leopold's maneuver. Step 2. Go down each side and locate the back. This is the second maneuver. Leopold's maneuver. Step 3. Gently grasp the lower portion of the uterus and feel for the head. Leopold's maneuver. Step 4. Turn and face the woman and repeat the steps. Assessment of the fetal heart rate and the point of maximal intensity. Location of the fetal heart rate in relation to the more commonly seen fetal position. LOA is left occiput anterior. LOT is left occiput transverse. LOP is left occiput posterior. LSA is left sacrum anterior. ROA is right occiput anterior. ROT is right occiput transverse. ROP is right occiput posterior. And RSA is right sacrum anterior. Remember, when performing Leopold's maneuvers, place the towel roll under the woman's right or left hip to displace the uterus pressure off of the vena cava and relieve pressure. You always want to remember to placental perfusion. You want to perfuse the placenta to give oxygen to the fetus. Uterine contractions are assessed by palpation, external and internal monitors. The accuracy of determining the intensity and resting tone varies by the method used. The woman's description and palpation are more subjective. The terms used to describe the woman's abdomen or fundus upon palpation: mild, slightly tense; moderate would be firm fundus, and strong would be rigid. Physical examination. Assessment of the uterine contractions. We're going to assess frequency, intensity, duration, resting tone, and then a vaginal examination. Frequency is how often they occur, the time that elapses from the beginning of one contraction to the beginning of the next. Intensity is the strength of a contraction at its peak. Duration, the time that elapses between the onset and the end of a contraction. Resting tone, the tension in the uterine muscle between contractions, relaxation of the uterus. Vaginal exam. Information obtained would be presentation, the position, condition of the membranes, ruptured or intact, dilation, enlargement and widening of the cervical os, effacement, thinning of the cervix, what percentage, station, engagement. You can look at your book, page 414, box 16-8. Assessment and nursing diagnosis. Laboratory and diagnostic tests. Analysis of urine specimen. Usually a clean catch would be obtained. They reveal hydration status, urine-specific gravity, color, amount, ketones, infection, white blood cells. Blood tests, such as a CBC and HIV. Other tests might be a type and screen. Assessment of amniotic membranes and fluid. Signs of potential problems, prolapse cord or infection. When the membranes rupture, the fetal heart tone should be monitored closely following rupture. The cord can prolapse with rupture of the membranes. Remember, when providing nursing care, we want to always do things such as evidence-based practice to support our nursing care. Physical care measures, general hygiene, nutrient and intravenous intake, elimination, and ambulation and positioning are all things that you want to provide for your patient. Encourage the mother to change her position often. This helps with pain as well as encouraging the fetus to descend into the pelvis. Adequate oral intake is needed to stay hydrated. IV fluids are typically given to enhance the hydration of the laboring woman. Typically, normal saline or lactated ringers are utilized during labor. Nursing support during the first stage of labor can be supported by the nurse, father or partner, doulas, grandparents, and sometimes siblings are present in the room. Signs and symptoms of stage 2 of labor: sudden appearance of sweat on the upper lip, an episode of vomiting, increase of bloody show, shaking of extremities, increased restlessness, pressure on the rectum, involuntary bearing down, and bulging of the perineum. Second stage of labor, the infant is born. It begins with full cervical dilation to 10 centimeters, complete effacement, ends with baby's birth, the upper limits for duration of second stage. This is a YouTube video of an animation video provided. Second stage of labor consists of 2 phases: the latent phase stage, which is relatively calm with passive descent of the baby through the birth canal, the descent, active pushing and the urges to bear down, signs and symptoms of impending birth. Preparing for birth: maternal position, bearing down efforts, feel heart rate and pattern, support of the father or the partner, supplies, instruments, and equipment must be present, birth and delivery or birthing room should be prepared. This is a picture with different birthing positions. This is a picture of a birthing bed. This is a picture of an instrument table. This is a picture of a radiant warmer for the newborn. This is a picture of a standard delivery room. This is a picture of the beginning of a vertex presentation where crowning is taking place. Mechanisms of birth: vertex presentation is birth of the head. Rittingen maneuver. The Rittingen maneuver is the birthing attendant assists in the birth of the baby by using his hands while steering the baby's head out of the birthing canal while applying pressure to the coccygeal area, protecting the perineum and assisting the mother with voluntary control of the birth and bearing down efforts, guiding her in breathing techniques, reminding her to pant while letting uterine force expel the fetus. See page 434. Birth of the shoulders, birth of the body and extremities, immediate assessment and care of the newborn. This is a picture depicting the Rittingen maneuver. This is a picture of a mediolateral and a median episiotomy. This is a picture of the third stage of labor, placental separation at birth. Placental separation and expulsion is firmly contracting fundus. There's a change in the shape of the uterus, sudden gush of dark blood from the intraotus, apparent lengthening of the umbilical cord, and vaginal fullness. This is a picture depicting a placenta. Maternal physical status. Signs of potential problems could be excessive blood loss, alterations in vital signs and consciousness. If these things are occurring, interventions will have to take place immediately. Care of placenta after delivery. If the placenta is not delivered within 30 minutes, it is said to have been retained. Interventions to remove will be undertaken. And then make sure that mom and baby are getting breast time, or encourage breastfeeding and provide bonding time. Fourth stage of labor is assessment, post-anesthesia recovery, care of the new mother, and care of the family, and care of the baby. 1 to 2 hours after birth is the fourth stage of labor. Recovery from birth, physical labor, anesthesia, but also a time to bond with the family. Vital signs every 15 minutes. Fundal measurements and massage if not firm. Fundus must not be boggy. We want to make sure we're assessing mom, assessing her LOC. We must be assessing her respiratory status and also assessing the infant. Thank you, and this is the end of Chapter 16.